Thank you, Dr. Rajeev. You brought out beautifully the overview of the updates on the management of atrial fibrillation, emphasizing the situations where you need to look at the anticoagulation, importance of catheter ablation in select patients, and above all, the risk factor management and the success of risk factor management in bringing out a better persistence of sinus rhythm in these kind of patients when they undergo procedures. So I would like to kickstart a discussion with a couple of comments. You mentioned about the genderless CHA2DS2-VASc. That's a very wonderful thing because of late we need to look at that. And the second one, you said about the quantification of the risk factor rather than just presence or absence of the risk factor. You mentioned about the incremental risk with the higher level of blood pressure and the duration of diabetes. But then if you look at the CHA2DS2-VASc currently, they just mention about the presence or absence and they look at whether the patient will require anticoagulation or not. So what do you think about the patients who have got a systolic BP of 130 versus 170? Do you mean the risk score becomes more, or a person with AF with a single risk factor? How do you address about this quantification of risk factors?
So that's a really important question, and that's something which I think as a general physician and cardiologist and electrophysiologist colleague, we all have to understand. The CHA2DS2-VASc score, while is a good screening tool and is a good tool for general physician and for our staff, and the nurse-led team so that they can identify a patient. But there are certain risk factors which did not make into that CHA2DS2-VASc score. For us to be able to understand, we need to understand how that CHA2DS2-VASc score was really designed. It was in about nearly 8,000 patients in a community. They did a propensity matching. They found some of these risk factors, and they chose the most important few risk factors, which resulted into a greater risk of stroke. There were lots of other risk factors which never made into that risk scoring system, like left atrial volume, presence of bad sleep apnea, bad overall metabolic disease. All these different risk factors did not make into, and AF burden itself. So if a patient is in a 20% burden versus one-off atrial fibrillation happening once every 12 months. So what are the differential risks in these particular patients? And these are things which needs to be discussed, number one. And number two, how bad is these cardiac risk factors? Are they good control or poorly controlled? Now, these all become really relevant when your CHA2DS2-VASc score is 1. Because that's when most people have confusion whether you should start anticoagulation or not. So if you have a poorly controlled hypertension and a CHA2DS2-VASc score is 1 because of hypertension, I will strongly encourage those patients to be on anticoagulation. But if you have a hypertension and even an excellent control of blood pressure, with the blood pressure ranging around 120 all the time, you may in those patients can say, okay, you do not have to be on anticoagulation. So that's how I use the quantification. A good control of diabetes or a mildly impaired glucose tolerance, and the patient has then since lost weight and is not diabetic anymore, should be unfair that this patient then remains on anticoagulation just because he had a high HbA1c at some stage and he was on.
Good evening, madam. Hello, good evening, madam. This is Dr. Lawrance.
Raji, please continue.
So those are some of the ways we normally look into incremental value of good control versus bad control, and duration of a certain disease. If you have a poorly controlled diabetes, now you are insulin dependent, or you have end organ damage to kidney and you are getting diabetic nephropathy, those patients are extremely high risk. So that's how it should be seen, in my opinion.
Okay, a very valid point. But what I suggest, do you think that this kind of risk quantification is required? The modification of the CHA2DS2-VASc is probably required, and I don't know validity of that.
Yeah, I don't think it is available at the moment, but more or less most physicians now realize it and they use that quantification. And if not, should be incorporated into the practice, yes.
Absolutely. So let's move on to the panelists. Do you have any comments on the this risk quantification, which is based on this hypertension level and diabetes. Any comments from the panelists?
Excellent presentation, sir. Almost he has clarified every aspect of atrial fibrillation.
Yeah, thank you. Thank you.
So, Rajeev, I have one more query. You beautifully mentioned for the areas where you will have a better outcome with catheter ablation. There is a recent paper in the AHA which was published where they presented at about AMAs plus pulmonary vein isolation. What's your take on that?
Sorry, pulmonary vein isolation plus?
Plus MAIS.
Yeah. So look, all the different, if you look at different strategies, each of those different strategies are good in select few patients. But every time you have done a proper clinical trial, like STAR-AF, we saw pulmonary vein isolation only stood out to be something which has shown best bang for the buck, if you understand what I mean. I am wary about the MAIS procedure itself because it creates lines, which then becomes a nightmare trying to then after that try to find those gaps and then try to do those. So every time the MAIS patient comes, it's almost a nightmare for us to try and find those lines and try to do those ablations. So I personally don't definitely promote MAIS procedure for AF ablation patients.
Okay. Anybody has any comment on this particular point?
Hi, Dr. Kokotkar here.
Yes,
I had
sir.
a question.
Yeah, please. Go ahead.
Yeah, I was curious about how you approach patients with their anticoagulation after ablation. Let's say 6 months later, they've done well. There's no recurrence. Let's say they have a CHA2DS2-VASc score of 2. What do you do with those people? Because I tend to stop their blood thinner and maybe put a loop recorder in if they're okay with it. Otherwise, it's a complicated discussion because we don't really have guidelines on how to manage their blood thinners after ablation.
So Siddharth, this is a good question. So in a patient who had an AF ablation procedure, at the current time, we keep them on anticoagulation for 12 months. After 3 months, you can have a discussion. If the CHA2DS2-VASc score is 0, after 3 months, you can have a discussion. If they have a loop recorder, which is a really valid point, and you can do a home monitoring, and if these patients are free from atrial fibrillation, yes, you can confidently stop their blood thinner because you've got rid of atrial fibrillation in them. If they do not have a loop recorder, unfortunately, post-AF ablation, you can have asymptomatic episodes of atrial fibrillation. Then it becomes really difficult to make that decision. Okay, just by a Holter monitor, you may not be able to pick up if they are having episodes or not. But presence of a loop recorder, a robust home monitoring service. We have a very good home monitoring service. And most of the home monitoring service, so say if you have a Biotronic loop recorder, there is every night you get a download. So pretty much the risk of missing an atrial fibrillation in those subset of patients is almost 0%. Now, the patients who have with a Medtronic loop recorder, and if they have a slow atrial fibrillation, unfortunately, you may not get alert on time. And sometimes Medtronic loop recorder, because of the algorithm, they have so many false positives that your home monitoring team might miss it. So those are caveats which you have to understand. And if you understand those caveats and you have a team who can manage, then once they have a loop recorder, you can stop them. Currently, there is a multinational clinical trial going, and our center, we are participating as well. The trial is called Ocean Trial, where we are looking at stopping anticoagulation 12 months after they have freedom from atrial fibrillation, and they get randomized into either taking aspirin versus nothing. And the results will be out in a couple of years' time, and hopefully that then will make into the guidelines. And we all will be able to then, based on guidelines, be able to confidently stop the anticoagulation, even in patients with CHA2DS2-VASc score greater than 2. Huh?
Okay, so that brings us to how do we pick up the AF burden. as a primary this thing or a post-ablation? Do we have to resort to more kind of these loop recorders, or just go by a prolonged Holter monitoring or something which will bring out a better one? Which of the two you suggest?
So look, it depends. So if a patient generally is a symptomatic atrial fibrillation patient, there will be certain subsets of patients who will remain symptomatic. The other patient group will be patients who nowadays are using smartwatches. There are devices such as LiveCore, which is an electronic device which is attached to your mobile phone, and it's like you can hold that in your hand and it can give you an ECG. Then the next level of devices we talk about are Holter monitors, which can be a 24 hours Holter, a 7-day Holter. Then there are devices such as HeartBug, which are 30 days. There are on transdermal patches such as ZeoPatch, which can be put in for up to 3 months. And then, of course, then you're talking about loop recorder. Depends on what subset of patient we are talking about. If a patient with a lone AF or a paroxysmal atrial fibrillation with 0 CHA2DS2 score, I will not say that you should have a loop recorder. I think they will be symptomatic. They can use watch. They can use these external devices or Holter monitors. But a CHA2DS2 score 2 or 3, you're deciding about stopping the anticoagulation in those patients. I think a more robust monitoring is going to be needed. And those patients, I will recommend having a loop recorder.
Okay, that's lovely. So coming to this risk factor assessment, what do you think about the addition of these biomarkers into this, number one? And number two, you mentioned about this causally if there's some mortality benefit. What's your take on these two?
So inflammatory markers, many inflammatory markers has been shown. We have recently just submitted a meta-analysis looking into different inflammatory markers, right? Starting from CRP to HSCRP to interleukin-6 to looking at MPO levels, calcium calmodulin levels, almost all those different inflammatory markers have been shown. Now, we all know atrial fibrillation is an inflammatory state, but we all know atrial fibrillation do coexist in patients with other inflammatory conditions. So it's very difficult to know whether this is an effect or the cause itself. So whether it's an association or the causation is difficult to know, but most certainly inflammatory markers have been shown to be associated with atrial fibrillation. So that's where I will stop. I don't have that much comment on the inflammation itself. The second point I think you had was about the causal AF.
Yeah.
So there are certain subset of patients with heart failure, TECI-mediated cardiomyopathy. Catheter ablation has been shown to reduce mortality. You'll maintain better sinus rhythm, and you'll be able to, in those patients, be able to reverse their heart failure, reduce ventricular arrhythmia, and will not only give them a quality of life, they will have a mortality benefit. So in a LV dysfunction with atrial fibrillation, most certainly AF ablation can be given them as a primary first line of therapy rather than antiarrhythmic medication. However, again, we need to choose those patients right. If you are too sick, you might end up having a device and antiarrhythmic medication. Heart function gets slightly better before they can have a procedure safely. And like all us good clinicians, we always will balance the risk and benefit and choose right patients to undergo ablation, because at the end of the day, they need to survive that 1.5 hours of AF ablation procedure. And you are only going to take subset of patients who will be able to tolerate the procedure.
Thank you, Rajeev. So for bringing up beautiful things and updates in the atrial fibrillation management and your experience. Wonderful talk at a very late time of, I think it must be 11 o'clock in the night.
It passed midnight.
Oh, that's really, congratulations to you and thanks a lot. And over to Dr. Lawrance.